So just as a quick point of introduction, I would like to thank Theresa Koleck for joining us today. She is a new assistant professor in the School of Nursing. She has a long relationship with Pitt Nursing. She did her undergraduate degree here, as well as her PhD, and just completed a postdoc in 2018 at Columbia University School of Nursing, where she worked with some of my colleagues, and then spent 2 years as a research scientist at Columbia School of Nursing as well, and came back here in 2020, so in May, as an assistant professor. So she does a lot of interesting work, particularly around mitigating symptom burden in patients with chronic conditions using data science, data mining, big data, using natural language processing. So that has some particularly interesting overlap with health services research, especially as we think about how to use electronic health records to look at quality of care and also improve outcomes. So Theresa, without further ado, I will pass it off to you.
Great, thanks, Grant. Can you guys see my screen? I did share it.
Yes, we can see it.
Okay, great. Well, thank you guys again so much for having me today to share my work. Let me just move my thumbnail thing out of the way there. There we go. And like Grant said, I started as an assistant professor in the School of Nursing in May. And also, as Grant said, prior to this, I was at Columbia University for 4 years as a postdoc, and then as an associate research scientist. And the study and results that I'm going to be presenting on today are from work that was completed at Columbia University. But when I started at Pitt, I heard about the new Health Services and Policy Research Hub, and I spoke with Haley and I spoke with Grant, and we thought that there may be some real opportunity to combine some of my biomedical informatics, data science methods with health services and policy topics of interest. So today, I am shamelessly seeking collaborators and experts in your area. So I really hope that after the presentation, it will spark some ideas, and really all ideas for collaboration are welcome on my end. Oh, I can't advance my slides. Let's see. Oh, there we go. So just to briefly introduce me, methods-wise, my work is located in the informatics and data science world. Data science is this combination of mathematics, computer science, and then some kind of domain expertise. And our goal is to always move from uninterpreted data all the way down to prescriptive intelligence. Within these methods, my program of research is dedicated to mitigating symptom burden in patients diagnosed with chronic conditions. All the nurses here know that assessing, monitoring, interpreting, treating, and managing symptoms are central aspects of nursing care. Symptoms are any subjective indications of disease and include concepts like pain, fatigue, disturbed sleep, depressed mood, anxiety, and the list goes on and on. Many patients experience one or more symptoms related to a health condition or its treatment, and symptoms can be really challenging to manage and influence a patient's mood, their psychosocial status, their functional status, their quality of life, disease progression, and even survival. So my team believes that secondary data reuse from electronic health records, or EHRs, has the ability to increase the quantity and quality of symptom research. In particular, text-based clinical notes are a really rich source of symptom information. Historically, patient symptom information has been manually extracted from notes by clinical experts. And if you've ever participated in a process like this, you know that it's extremely labor intensive, it's time consuming, it's expensive, And kind of most importantly to us, it really lacks scalability. That scalability necessary to extract symptom information from large quantities of notes for hundreds to thousands or even millions of patients for data stored in the electronic health record. So we've been looking at using novel data science approaches like natural language processing, which we abbreviate as NLP, to help overcome some of these scalability challenges related to manual note review. So NLP is any computer-based algorithm that handles, augments, and transforms natural language so that it can be represented for computation. And it's used to extract information, capture meaning, and detect relationships from language-free text through the use of defined language roles and relevant domain knowledge. So simply put, as you see in the first bullet point there, natural language processing is the use of computers to interpret and extract meaning from text. So members of my team, including myself, as you can see on the slide, have recently synthesized the literature on the use of NLP to process or analyze symptom information from notes. And we essentially found that NLP tools are currently being used to extract information from diverse note types written by a variety of clinicians on a wide range of symptoms across clinical specialties. But the majority of this previous work has focused on the use of symptom information for physician or medicine-focused tasks. So things like disease prediction, rather than on the investigation of the symptom itself. So these tools may be really insufficient for our more symptom-focused tasks. And as nurses, it's really critical that we develop and use NLP approaches that are designed for the specific purpose of studying, our core nursing concepts of interest, including symptom documentation in the electronic health record, among others. So I want to make the challenge here of natural language, of free text very clear. Symptom language documented by clinicians, as you know, is very complex. The presence of a single symptom concept can be indicated by many, many different synonym words or expressions. So think of something like fatigue. There are so many ways that we can say fatigue. We could say feeling tired, drowsiness, energy loss, exhaustion, groggy, sleepy, sluggish, tires quickly, weary, and the list goes on. And it really goes beyond words that are contained in standardized vocabularies to more colloquial phrases like wiped out, low energy. It can include misspellings, which if you ever looked in the notes, fatigue is very frequently spelled, incorrectly. You'll see all combinations of U's and I's and Q's and G's. And also abbreviations like TATT, which stands for tired all the time. Now, the other thing to think about with documented text is that the mere presence of a symptom word or expression may not indicate that the patient is actively experiencing that symptom. So, for example, a symptom may be negated. It may say no fatigue, does not complain of fatigue. So while the word is clearly there, it's not an active problem for the patient. Another good example of this is something that occurred in the past. So if the note would say not currently fatigue, or PMHX, past medical history of fatigue. So NLP can really help us resolve some of these major challenges. Specifically, a new generation of machine learning models that we call language models can be used to help discover synonym vocabularies from large bodies of text. I'm gonna walk you through what we did because I really want you to see what it looks like, because I think that's gonna make it come more alive. But what these language models come down to is that they are statistical representations of a body of text. We specifically use language models called word embedding models. And word embedding models use neighboring words to identify other potential synonyms. And what that means is that if two words have similar neighbor words, it's likely that they're appearing in the same context and that they may be synonyms. So that, on a high level, is how we use the computer to identify these potential synonyms. However, these new NLP methods have not previously been used to identify symptom information in the clinical notes. So I am, now that we got through the introduction, going to describe a method that we developed that utilizes standardized vocabularies, clinical expertise, and these NLP tools to generate comprehensive symptom vocabularies to identify symptom information in electronic health record clinical notes. And we actually did this for 57 distinct symptom concepts. I'm going to present pilot data that we obtained for 5 diverse symptom concepts, specifically constipation, depressed mood, disturbed sleep, fatigue, and palpitations. And I'm also going to report our evaluation of the NLP tool's symptom identification performance. So we really completed 2 overarching goals as part of this study, 2 main research activities. The first was vocabulary development, and then the second was evaluation of the NLP system's ability to identify the symptoms in the notes, to label the symptom information. Now, as I present the next set of information, I'd like you to think about opportunities related to health services and policy research combined with this method. And I can see this connection happening in 2 different ways. The first could be associating symptom information from notes with health services and policy research outcomes of interest. And then the second would be using this method that I'm going to present to develop a vocabulary for another concept of interest. So let me start by telling you about the NLP tool that we used. It's called NimbleMiner, and it was developed by one of my colleagues and his team at Columbia University. His name's Maxim Topaz. And NimbleMiner is an open source and free NLP, our shiny application, if that means anything to you. What it comes down to is it's just the software. And it enables users to mine clinical text to rapidly discover large vocabularies of synonyms. So this is the main publication that you would want to go to if you want to learn more about the NLP system that we used. Or you can visit Dr. Topaz's GitHub page, and you can even download the NimbleMiner system onto your machine if you're interested. It's really easy to remember where it is if you just look up Max. So mtopaz/NimbleMiner. So let me give you an overview of this system. So briefly, to build vocabularies within Nimble Minor, the user imports a large body of relevant text and a preliminary list of words and expressions for a concept of interest. In this example, they're showing falls. The software performs text pre-processing all on its own, including the removal of punctuation, modification of letter case, and it converts frequently co-occurring words to 4-gram expressions, which just means that phrases that are frequently co-occurring will create them in chunks, up to 4 words. Then Nimble Minor builds a language model that we talked about earlier, and it suggests additional synonyms to the user. The user can then iteratively accept or reject words or expressions suggested by the system, and you'll see that depicted here in step 3. So these were like the suggested synonyms for fall, and the user saying, oh, slipped is good, fainted is good, tripped is good, but hit her head, no, system, like that's not a good synonym, but we can see why you identified that. And you just keep doing this process until no more relevant synonyms are suggested by the system. Following discovery of synonyms, Nimble Minors use to identify positive instances of a concept in the text. So let me show you what that looks like in real life. So this is RStudio. If you're familiar with RStudio, you're probably very comfortable with this screen, but it's just an integrated development environment for R. And you'll see the code here that's actually running Nimble Minor behind the scenes. But as a user, all you need to do is click this little nice Run App button, and it will bring up this real nice user-friendly interface. And this is the screen where you import your large body of text and build your language model. And again, that's not you doing it, that's all working behind the scenes. You can then begin to explore synonyms. This is an example for pain, one of the synonyms of pain. And you can see that the system is identifying some potential synonyms for us. Some of them that they identified was abdominal discomfort and abdominal pain, spelled both correctly and incorrectly, as potential synonyms. And you as the user would go through and say, yes, computer, that's a good synonym. No, computer, that is not a synonym. So here are some examples of irrelevant terms that the computer identified as potential synonyms for pain. And you can see why. You can see why that these terms are occurring in a similar context as synonyms for pain, but don't specifically refer to our concept of pain. They're pain medications, things like Dilaudid, things like morphine. You can also set up terms that will be used for negation. When you're labeling, if just because a symptom term is physically in the text doesn't mean that the patient's actively experiencing it. We have tons of different terms for negation, and you can modify them, add your own. So things like no, absence of, etc. And then after you're all done creating your vocabularies of interest, you can label your notes for the presence of a concept. And here's just an example of what this would look like. The top one is a positive, this is a positive instance of chest pain. And the bottom one is a negated instance of no pain. And what you end up with from the labeling process is this spreadsheet where each row is a note and each concept is a column with a notation of if the concept was positively documented in the note or not. So then you can take that information and do any of the additional analyses that you're interested in to answer your research question. So that was a real quick overview of the NLP tool. So now I'd like to get into specifically what we did. So again, as a reminder, we had two major phases. The first was our vocabulary development, and then the second was evaluation of the NLP tool for the evaluation of symptom identification performance. The vocabulary development phase consisted of 3 steps. The first was to identify symptom concepts and develop preliminary list of synonyms. The second was to build language models for synonym discovery. And the third was to generate comprehensive vocabularies for each symptom concept. So in step 1, the identifying symptom concepts and developing preliminary list of synonyms, we started by reviewing a widely used medical terminology, SNOMED, which you've probably heard of if you work in medical terminologies. Probably even if you haven't, SNOMED is a pretty popular one. And we use SNOMED to create a catalog of candidate symptom concepts. And the candidate symptom concepts were then reviewed by nurse clinician scientists. We identified 57 unique candidate concepts that we wanted to create vocabularies for, that we felt it was important to create vocabularies for. And you'll see that we have, a real wide range of symptom concepts here, everything from abdominal bloating to malaise, to weakness, to a lot of cognitive function things, etc. So next, we created a preliminary list of words and expressions for each of the symptom concepts using the Unified Medical Language System, or the UMLS. And the UMLS is this really neat compendium of many health terminologies. And we use these synonym lists over here to begin developing these preliminary list of synonyms. This example was for nausea, of course, which you could probably tell from all the synonyms over here. Then we had nurse clinician scientists review these lists and make any recommendations for changes. If they thought there should be additional synonyms, if they didn't think a synonym captured the concept. So here is the preliminary list of synonyms for fatigue, just as an example, to give you an idea of what this looks like. Again, the large extent of variability within this list. So on to step 2, we used building our language models for synonym discovery. Now we use 2 large bodies of text to generate 2 corresponding language models in NimbleMiner. The first was EHR clinical notes, and the second was PubMed abstracts. Now we use 2 bodies of text because this would allow us to extract complementary and a real diverse range of synonyms. EHR clinical notes would include more of those jargon terms, while PubMed abstracts have more standardized synonyms used in the scientific literature. And because, we didn't know what people would ultimately be using our synonym symptom list for, we felt it would be beneficial to include both. So now this is the part I love. So for the EHR source, we obtained all available patient clinical notes, which was about 5.5 million notes from the Columbia University Irving Medical Center Clinical Data Warehouse that were authored in 2016. These notes represented about 1,400 unique note types. They were from an array of specialties, different settings. We had inpatient, outpatient, emergency room, and written by all different members of the healthcare team. So we included, everyone. We included nurses, physicians, social workers, respiratory therapists, everyone. No one was excluded. And these notes were from about 238,000 distinct patient medical record numbers. For the PubMed source, we extracted all available PubMed abstracts, only about 94,000, which seems really small in comparison to how many notes that we had, but containing mesh or keywords related to the pilot symptoms of interest. And this was the query that was used to obtain those abstracts, if anyone is interested in that. So we inputted our EHR and PubMed large bodies of text into NimbleMiner and built the language models using the system. So that then took us to step 3, generating those comprehensive vocabularies for each symptom concept. So after we imported the text, we then imported those UMLS informed preliminary synonyms for each pilot symptom into NimbleMiner, like that list that I showed you for fatigue earlier. So based on the language models built in step 2, NimbleMiner suggests similar terms for each imported synonym. 2 individuals with expertise in symptoms independently reviewed and accepted or rejected suggested words or expressions for each symptom concept of interest. And it was important to us to have 2 reviewers, just of course because people make different decisions on what they want to include and not, and we wanted to be as comprehensive as possible. So the 2 reviewers compared lists of words or expressions, and they discussed any discrepancies, and we had an adjudicator to make, any final decisions that needed to be made. So the output of this step and of the vocabulary development in general were the comprehensive vocabularies for each symptom concept. So then finally, we moved on to evaluation, and we evaluated NimbleMiner symptom identification performance for each of our 5 pilot symptoms. To perform the evaluation, we created a gold standard set, that's what you would call it, of manually annotated clinical notes. And we had 2 nurses perform this manual annotation. It's very time consuming, and but you want to do it well to be able to test your system. But I don't want to spend too much time talking about how we created the gold standard note set. But if anybody has questions, about that process, I'm happy to answer them. So then to formally evaluate the performance, we compared NimbleMiner's identification labels to our manual annotation, and we calculated recall, precision, and F-measure. And we really like F-measure because it's this test of accuracy that considers both precision and recall. And just when I'm showing the results, if you're not familiar with this, the thing to know is that F-measures range from 0 to 1. 0 means that you have really poor precision and recall, all the way up to 1, where you would have perfect precision and recall. So let me show you some results. This is showing how many, synonyms we started out with from the UMLS and expert informed, how many were additional synonyms were identified by both reviewers, and then also uniquely identified by one or the other reviewer. And I think this shows that it's important to have one or more user, going through and picking the synonyms. But the increase in synonym vocabulary size ranged from double for disturbed sleep to almost an 11 times increase for palpitations. And the synonym words and expressions represented abbreviations, like for palpitations, for palps, misspellings. Palpitations is apparently really hard to spell or type too, and unique multi-word combinations. I told you it created like those 4 grams, those 4 words, unique 4-word combinations. So on this slide, and then on the next, are the expanded vocabularies for fatigue. And you might actually be able to see this because you're looking at your computer, but it's not so much that I wanted you to be able to read it. I just, for the more visual people, to show how much these vocabularies were expanded, from the first list that I showed you for fatigue. And it just continues on. So overall, F measure ranged from 0.8 to 0.96 for our 5 pilot symptoms, all indicating good or excellent system performance. We also investigated instances of incorrect labeling so that we can continue to improve our symptom lists, as we move forward. And the most common reason for false positive symptom identification was due to a term being relatively far from a negation term. So often in notes, physicians, nurses, they'll write this really long list of symptoms, that a patient doesn't have. So they'll write no complaint of A, B, C, D, E, F, G, H, I, and it just goes on and on and on and on. And maybe our symptom of interest was I, and it's many, many words away from the negation term, and the system didn't pick up on it. So other common causes of false positives included negation terms not being included in the software, which is an easier fix. We can just add them. Some of the ones that weren't included previously were like never exhibited or HO for history of. There was also non-relevant use of a symptom term. And a good example of this that we found was sluggish, referring to pupil response rather than a mood state. Or excuse me, sluggish being referred to a pupil response rather than fatigue. We also had instances of depression referring to like a diagnosis rather than a mood state. That one is kind of challenging to remedy. Another problem was potential medication side effects rather than an active problem. So, someone writing like, oh, this medication may cause drowsiness, and that was being picked up as fatigue. Yeah, so those were kind of like the main causes of our false positives. And then a lack of synonym words or expressions for disturbed sleep and constipation were the main reasons for mislabeling of positive instances. So some of like the phrases that we did not have in there were like, did not sleep well last night, unable to sleep. And so there's an opportunity to expand those vocabularies even further. So one of the main limitations of this study was that all clinical notes were obtained from a single medical center, and the generalizability of symptom vocabularies really needs to be tested, potentially refined and validated using data from additional medical centers. And we've started this process of replicating the symptom vocabularies with UPMC notes. And we're waiting for our first data pull now. And we're working with the R3 individuals from the Department of Biomedical Informatics to have that done. And they've been wonderful to work with. So in conclusion, it's our hope that nurse scientists will be able to take advantage of the comprehensive symptom vocabularies that we're developing, and we're going to continue to refine for their own work. We try to, by us creating the vocabularies, you won't have to go through all that development step. You should be able to hopefully move straight to the labeling. So the ability to extract symptom information from EHR notes in an accurate and scalable manner has the potential to greatly facilitate symptom science and really, I think, potentially health services and policy research as well. As an example of an analysis that we did in this realm and we've submitted for publication was using the vocabularies that we created to examine the association between symptoms and emergency department or hospital admissions from home care patients. So, seeing the prevalence of different symptoms in home care and then seeing if certain symptoms or the number of symptoms being documented were associated with these readmissions. And it turns out that they were. We're also using these symptom vocabularies for other things. Another project that we're doing at Columbia is using these symptom vocabularies to look at COVID symptoms in the emergency department. And then if that patient ends up testing positive or negative for COVID. So before I open this up for discussion, and this is great, we have 20 minutes. That's exactly what I wanted to have left and talk about how we can collaborate. And I really hope that this sparks some ideas. I just need to thank my collaborators at Columbia and my current funding source, K99 ROO from the National Institute of Nursing Research. And so that you remember me, because this is what most people remember about me, is that I have a Myers parrot who is my wonderful coworker. He is pictured here. He's been so happy to have his flock home during the pandemic. And then this picture, this comic that Chicken Thoughts created. This is not my Twitter handle. This is credit to the artist of the comment. This is exactly what it's like working with a parrot from home. So with that, thank you, and let's open it up for discussion.
Great, thanks so much, Theresa. So if anyone has a question, please feel free to unmute yourself and ask away.
Hi, Theresa. This is Theresa Thomas. Can you guys hear me?
Hi, Theresa. Yeah.
Hi, Theresa. Wonderful presentation. This is so exciting. One question before I have some comments about integrating this into policy and health services research. Is there a way to look and see not just who put into the medical record information about symptoms, but more fine-tuned than that, to say whether it was the patient bringing up symptoms sort of, just naturally in a conversation versus the provider asking about, do you have this symptom? Do you have that symptom, et cetera?
Yeah, so that's a great comment, Theresa. With the notes, right, it's limited to whatever was documented and how they documented it. One of the next steps in this NLP process is to get even more into the context, like moving beyond just like finding the word and doing more like intelligent context related things. So I would think that if it was documented, like the patient stated, we could find it versus,
Yeah.
I evaluate it. But if it's not, documented by the clinician, I think that might be challenging.
Right. Yeah, no, I understand that. And I think, in some respects, if you had a measure of the length of text about a specific symptom, so then it really doesn't matter if the provider brought it up, if the patient brought it up, but at least if you knew that, say, there were so many words that were talking about fatigue or talking about pain, then it really doesn't matter, well, I'm interested for my research in who brought it up, because we know that a lot of times patients don't bring up symptoms unless prompted by their clinicians, and that has implications. But that, well, who really cares as long as it's being discussed and there's a lengthy note in the medical record, then sort of a null point. Anyways, it sort of bleeds into a suggestion that I have in thinking about symptoms. I know as nurses, we think about symptom management as sort of the bread and butter is what we do as oncology nurses. But I think sort of translating that into policy or health services research, thinking about symptoms as a measure of quality within oncology care and as a measure of patient-centered care. I think, usually our other clinicians describe symptoms more as patient-reported outcomes. And of course, that sort of opens up several possibilities to think about, well, what does that mean for different types of care delivery systems, especially the oncology care model, palliative care models, patient navigation models. So that may be some way to think about how you can use this mode of looking at symptoms, in terms of both evaluating these different types of care models, and obviously, as you pointed to at the beginning of your presentation, looking at how they're associated with outcomes, which I think would be a really interesting question. But I'm interested to hear what others think about as well. But that may just be sort of a framework change. And it really is just sort of semantics about symptom management versus these other labels for the same thing.
I really like that symptom documentation as a measure of quality. I've never have thought about it that way before, but I think that's so true. And I can already tell you that when we've looked at it by the different note types, like the amount of symptoms, the symptom information is very different depending on the specialty.
Yeah.
And the oncology providers, like the hem-onc notes,
and
they
even
usually have very detailed information.
Right. And I'm sure that's a lot about, looking back to what's important for them. And, it's more symptom driven, what's a quality metric. So obviously pain is probably the biggest one, because that's seen as a main quality indicator, how well cancer patients' pain is managed. So it may not be, that you're looking at a composite symptom profile, but honing down to specific symptoms, and thinking about, doing a deep dive into how that symptom is discussed, managed, and outcomes related to that as sort of an assessment of the care coordination, quality of care, again, all of these ways that, we're trying to reform oncology care.
Yeah, thank you, Theresa.
Mm-hmm.
Hi there, this is Haley Garmack. Thanks for the presentation and really breaking down the science that goes into natural language processing. I know what kind of started us talking was that Optum presentation back in, I think, June or July.
Yeah.
And something that Optum does as part of its product is it actually has the NLP as a product for us. So this is really helpful to kind of understand the potential derivation. Although I think their method is somewhat proprietary, they won't necessarily divulge it. We just have the end product. Something that I'm really interested in using their NLP product for in the behavioral health services policy realm is symptom identification for depression and anxiety screening. So I know some of the NLP products that they provide are like GAD scores and PHQ-9 scores. And I'm hoping we kind of have a potential project underway for examining differences in outcomes for depression and anxiety with treatment by physicians and nurse practitioners, just as like a potential health services research idea. Interested in your thoughts on that.
I mean, I'm always in favor of adding this information from the notes to any of the more standardized information that you have, you know, like you were saying, the scores, because I think it creates like such more of a comprehensive picture. And from my work, if we limited studying symptoms to like ICD codes, we have not found that to be informative. That's limited to reasons like why I would go to the emergency room. So adding the note information, I think, could be very beneficial. So when you said screening, are you looking to see like if that person eventually has a diagnosis, or are you looking more towards like an outcome of their treatment, or both?
So we're actually using the diagnosis to limit our cohort to a population of patients with the diagnosis. And then we're looking at progress and outcomes on the diagnosis, given the scores on the screening methods.
Yeah, I think I think that's a great idea, and I think this would be a great additional piece of information, you know, that you could bring in to your prediction of what the patient outcome, you know, will be. And I like how, you know, you're going to kind of like stratify it by some important predictors that you have, like the provider type, you know, to see if that has an impact on these outcomes as well. But I think this could help you get at some of the outcomes like along the way.
Thank you.
Does that answer your question? I'm not sure.
Okay, it was mainly just like a sharing of an example of how we may be employing this in health services and policy research, and if you had any feedback or interest in that.
No, I think it's a great example, and I definitely would like to talk to you more about it offline after we're done. That'll be great. Thank you.
So, hi, Theresa. This is Jen.
Hi, Jen.
How are you? Nice. I appreciate great presentation.
Thank you.
So, I'm really interested. One of my projects involves patients with ADRD, Alzheimer's disease, or related dementias in the primary care setting, and oftentimes they come in with a caregiver, and one of our interests is seeing how often providers ask about behavioral symptoms, which are a little bit different and are also not necessarily reported by the patient, but by the caregiver, but would be documented, I believe, similarly. So I'm curious if you think that using this type of methodology might help us to identify if caregivers are reporting things like agitation, restlessness, wandering, different collection of terms, but they are symptom descriptors, so to speak.
Oh, absolutely. I mean, especially if this is something that you're describing that is typically captured like in a note,
Yes.
You know, and nowhere else. Like this is where, you know, you are going to get that information.
Okay.
And the beauty of like the method, right, is if there was a specific behavioral symptom, you know, that you are interested in you know, we could work and develop a vocabulary, you know, specific for that behavioral symptom that then we could then use on all your notes, and you could just, you know, use moving forward, and you never have to do the development really again.
Okay.
We've also have had people take like an initial vocabulary that we developed and kind of like modify it, you know, for their own usage. So again, they're not starting from scratch. But yeah, I think that would be like a perfect example of a application for this. And that would be really interesting, because probably not many people have looked at that, right?
It's a commonly reported symptom, but I don't know how often, you know, I don't know, again, if it's really, if there's a body of descriptors that have been evaluated and checked in the way that you have with the in terms of reliability. So that would be really good. That would be, I'm interested. So we should talk.
Okay, we will talk too.
Thank you.
Yay, collaborators. It's working.
It's working.
Hi, Theresa. This is Dianxu. I have one question. So first, thank you for your great work. It's a very interesting topic. And
Thank you.
I have one question. Is there any way to possibly continue to quantify the symptom? You know, you mainly actually that's a vocabulary symptom, but if can be possibly further quantified, maybe make it more useful, in analysis. I'm a statistician, so I'm most likely I'm interested in numbers. So that's why I ask a question.
Could you? I'm not exactly sure what you mean by having it qualified.
Quantify, I mean.
Oh, quantify.
Yeah.
So the system, I didn't want to get too far into it. I mean, one of the things that the symptom pulls out that maybe comes back to actually one of Theresa's first point about like how much is like being documented about a particular symptom. So the system is able to pull out, like we also get a count. So like how many times a synonym like occurred in a note, like more so than just a binary, like yes and no.
Mm-hmm.
I think eventually that one of the next steps that we could do in this, beyond like more of this just like text mining, like is the symptom there, is it not, is to move more to machine learning of like how probable is it that this symptom is documented, you know, in this note, and that might get at a more like quantitative, like 0 to 1, like probability of the patient having this symptom. Mm-hmm. But we're not at that step yet.
Okay, thank you.
Thank you.
Any other questions for Theresa? Well, if that's it, Theresa, I want to thank you so much for joining us today. This is really great. I think there's, as you can tell, lots of opportunity for overlap. I would love if you would take a look at the documentation in Optum and see what they're doing in terms of data mining. And I'd love to get your take on what you think in terms of what they're doing, because as Haley said, we're going to try to use some of they use data mining to create sort of fixed fields like you're describing to sort of quantify the presence or absence of certain, actually I'm sort of getting out of my scope here, but it'd be great for you to look at the documentation and see if you sort of buy what they're doing before we start using it broadly. Amy, not to put you on the spot, but I'm going to put you on the spot. We have 2 weeks from today is our next Colloquium presentation on, so that would be the 13th. Is that right, Amy?
Yep, that's correct.
Okay, so we'll be meeting again on the 13th, and who is giving that presentation?
Ooh, let me double check on that.
Okay. Yeah, sorry to put you on the spot.
It's going to be someone great, I promise.
Okay. Well, I'll tell you what. Again, thank you, Theresa, so much. And please reach out to Theresa if you have any questions or are interested in some collaborations. Again, the 13th is our next meeting. We're going to start building up our spring calendar. So if anyone is interested at all in participating in the spring, please do reach out to me, Haley Garamack, and or Amy Comadino, who's a graduate student in the DNP program that's been helping us organize these events. And again, I want you to feel very free to do anything from what Theresa did today, as sort of a career overview and an introduction to your work, or a paper in progress, or if you want to try out a presentation for a conference, we can do that as well. We're trying to be very fluid in the kind of work that we're interested in. So do we have, Amy, the next speaker?
Yes, it's going to be Julian Rodakowski.
Great. So Julene is a professor in the Department of Occupational Health, and she is a health services researcher. Just got R01 funded. I'm not quite sure what she's going to be talking about, but I'm sure it'll be good. So please check your email for the next event. And thank you so much, everyone, for joining us. This was great. Thanks again, Theresa. Really appreciate it.
Oh, thank you guys. Looking forward to collaborating.
All right. Take care.
Bye.
Thank you.